Okay, now we can start.
Recording, okay, good. Okay, so Assalamualaikum everybody. Thank you for this kind invitation, and thank you very much, Odoric, for this kind invitation for me to talk about something that I've always had a passion about, which is endometriosis. So I'm going to I'm just going to share with you my experience with endometriosis mapping with transvaginal ultrasound. So number one is we're going to ask ourselves, why do we need to map the endometriosis? Why do we need to map it accurately and comprehensively? Number one, it gives us the chance to explain the disease to the patient. Number two, it also allows the prediction of the severity of the disease. I will show you later on, because the most common staging system for endometriosis is actually the revised American Fertility Society system. And that really accounts for the severity of the disease with regard to the adhesions. But it doesn't really predict the incidence of what you call DIE, right? Which is a deep infiltrating endometriosis. So the transvaginal ultrasonography will allow us the prediction of the severity of the disease. It is therefore very helpful for us in surgical planning and counseling, because DIE can be quite bad. It can invade into the bladder. It can cause urinary constriction. It can actually invade into the rectum, and then the pouch of Douglas may be obliterated. So if we don't know, we don't plan, when we go in and we do the laparoscopy, we may be in for a very big surprise. Okay, so this means that we can even have a look even before surgery itself, and this allows us to stage the disease with transvaginal ultrasound. Okay, so what does a detailed scan for endometriosis entail? Basically, the first step is actually not very different. We look at the uterus, we look at the direction, deflection, mobility, the smoothness of the posterior wall especially. And we also look at the ovaries, again the same thing, the mobility, the relation to other organs and so on. Then the additional steps include looking at the anterior compartment, looking at the bladder and the ureter, and also the posterior compartment, which includes the pouch of Douglas, rectum, the uterosacral ligament, the rectovaginal septum, the vagina, and also presence of any endometriotic nodules, which will then allow us to plan what to do for the patient. So this is a very important paper which I always refer to, and it's by the IDEA group, which is the International Deep Endometriosis Analysis Group. In 2016, they published this consensus statement, which basically shows the benefits of doing endometriosis mapping for the patient. And essentially, a transvaginal ultrasonography is a dynamic ultrasound. That means you can actually assess the pelvic organs and their relationship in real time. This is very unlike either a CT scan or MRI, where the patient lies down, you take a picture, and then after that you analyze the picture, because then it's no longer dynamic but it's static. Okay. So what they really suggest is actually a four-step evaluation in endometriosis. Again, this is very similar to what I've said earlier on. The first step is routine, which is what we are already doing. We look at the uterus, the annexure, but we must also look for signs of adenomyosis, which is very important, right? And following that, we look at the soft markers. So there will be things like site-specific tenderness and ovarian mobility. So something that either MRI or CT scan cannot do, because you don't have a probe in the vagina trying to assess or to push. You don't know the dynamic relationship between the two structures and the organs. Okay. The third step they suggested is the assessment of the status of the pouch of Douglas, and then using real time again, based on the sliding sign. So whether the uterus can slide smoothly across the cul-de-sac or not, whether you can see any adhesions, whether you can see the uterosacral ligaments which are stuck onto the back of the uterus. And lastly, of course, you assess for DIE nodules in both the anterior and the posterior compartments. Okay, so this is just an overview of what they are doing. Basically, anterior compartment over here, you want to look at the UV angle. You want to look at the bladder base, whether there's endometriosis. You also want to look at the bladder dome to see whether there's endometriosis or not. Once you are looking at the bladder, you can turn to the lateral angles. You can actually see the ureter. And sometimes you can see how close the ureter is to the ovary, which may be affected by an endometriotic lesion. So once you see that, you will realize that the ovarian endometrioma is stuck to the pelvic side wall with the ureter just crossing underneath the endometrioma. So you may need to be a bit more careful. Again, the same things. Then if you go on to the posterior compartment, it is basically looking at the rectal vaginal septum and then going outwards towards the cul-de-sac and then going towards the rectum and tracing the rectum all the way up even to the sigmoid colon. We know that endometriosis is mainly concentrated in the pelvis. So of course, in terms of viewing the large intestine, we won't be as good as the MRI, which can see across your transverse and to your ascending colon. We can probably only see up to the sigmoid colon, but I think that's generally very, very good and is good enough for endometriosis. We also need to look at the posterior fornix and so on. So I think those who are not familiar with this paper, I would encourage them to read this paper. It's really a very good paper to see, to explain what we are trying to look at and what we're trying to look for in so-called endometriosis mapping. Okay, before we start, I just want to highlight in this endometriosis scanning, there are a few what you call bad signs that we look out for, and these are things like the question mark sign, right, which I'll explain to you. If there's adenomyosis, again, to me that's a bad sign because adenomyosis is something very hard to treat. It is in the uterus. There is no good solution. If you want to suppress it, you can't get pregnant. You want to get pregnant, you cannot give medication. So to me, adenomyosis is not a good sign. There are also things like the Indian Headdress sign, or some people call it the most antler sign, depending on which country you are in. Then the Comet sign also. Then of course the presence of nodules, individual nodules that you can actually see as low echo lesions in the thickened ligaments or thickened tissue. So this is actually a so-called normal uterus. You can see the normal outline, the shape. It is quite slim. So we look at the direction, whether it's anteverted. We look at the flexion. Flexion is very important because if uterus is anteverted and retroflex, that is the first suspicion that there may be something more than normal. Okay, the flexion of the uterus will tell you whether there's a possibility of the uterus being in a fixed position or not. Okay. Then we also look at the smoothness of both the anterior and the posterior wall, and by pushing against the uterus, you can actually see whether there's a sliding sign or not. Of course, next we want to look at the myometrium for any signs of adenomyosis. Some people will look at the junctional zone, which is the zone between the normal myometrium and the endometrial cavity. There are some normal measurements, but I feel that for me it's not so important. I don't usually look too much into the junctional zone because I don't feel that it's that useful for telling me whether there's adenomyosis or not, because there are stronger signs that tells me whether there's adenomyosis or not. Okay, so these are some pictures of what you call abnormal so-called position of the uterus. This is what I alluded to as the question mark sign. You can see the uterus shape is in terms of a question mark here. So the uterus is actually anteverted but retroflex. So to me, this is always a danger sign because it shows that the uterus is actually bent backwards and is puckled. Yeah. So you can actually, in this picture here, you can actually see the same question mark sign over here, but you can see in the mid-uterine segment posterior wall, there is a puckering down there. Okay. So to me, what it means, the puckering is a pulling of the tissues into the uterus. So that's why it causes this flexion of your uterus backwards over here. So again, these are two other pictures that show you the same thing over here. Okay. So these are all my scans. The only thing different is that I know in many places they tend to do the scan with the in this way is but for me I've been trained to scan it in this inverted fashion. Yeah, so I'm not sure whether you are used to it now, but if you're not used to it, so maybe you can just adjust your position a bit and bear with me, because I'm used to scanning in this position. So all my scans are going to be like this. Okay, so this is the vagina and this is the probe going upwards here. So rather than coming down from the top. Okay. So in this instance, you can see the uterus is actually very smooth, right? It is sliding very well, right? There's elasticity in the tissues, okay, right? Over here, you can see there's sliding very well over here, right? Yeah, the back also. Okay, so this is just normal uterus, which I'm going to show you first. Okay, and then you can see the back over here. The tissues are very elastic. The pouch of Douglas, you can see, is free over here. You can see some free fluid over here. When you lift up here, you can see that sliver of free fluid. So the back of the uterus actually is very free actually. So the uterus slides both anteriorly and also posteriorly as well. Now, this one is starting to be abnormal over here. So this is just a still picture, but you can see over here, the center of the back of the uterus here, there's starting to have a bit of a buckle here already, right? So when you do the same kind of a sliding test, right? Yeah, you push, right? There's less movement of the uterus. You see, it doesn't move, right? The whole uterus is actually fixed. It doesn't really move very much, you know. So you try to push, right? But you know, it's not as good as the other uterus where you can actually slide like this, huh? Right? So you must look out for this buckle here already. So this just shows you that this patient has got adenomyosis, right? Over here. So there are a few hallmarks for adenomyosis. You can't say which one is more important, but they all add up to the same so-called diagnosis. Number one, of course, is the thickened, and coarse myometrium. Number two is you get this kind of a sun ray pattern going up here, mainly because of the tissue scarring within the uterus itself. Number three is you may get cystic spaces within the wall of the myometrium. And this probably gives you a telltale clue also, because you can see that the ovary actually is stuck to the back of the uterus over here. So there must be some overlying endometriosis which may have invaded into the uterus, right? Causing also the ovary to be stuck. So again, we have to look at the whole picture when we scan. We cannot look at any individual detail by itself. Okay. This is a picture of a scan picture of the uterosacral ligament that is stuck over here. So although the front of the uterus here is nice and smooth and sliding over here, right? Even to the pouch of Douglas there's a space over here. But here you can see the uterosacral ligament is stuck to the back of the uterus, right? It is thickened, it is stuck to the back, right? There's less elasticity and it doesn't move that much. So this is the USL here that's stuck to the back of the uterus. Okay. Okay, so after having assessed the uterus, we look at the ovaries. So the finding of a normal ovary does not mean the patient have no endometriosis. We must also look for other telltale signs, and some of these include things like the uterus being fixed to the uterus medially or to stuck at the fundus, you know. Or sometimes it is actually stuck to the pelvic side wall, it doesn't move, or it's actually very high, or it may get fixed to the uterosacral ligament. So this is a picture here that shows you the left uterosacral ligament over here, right? And you can see the ovary just next to it. Okay, it's not so bad. It's fairly mobile, right? You can see the ovary over here. Let me show you again. Right, external iliac, okay, and then of course your ovary over here. You can see the mobility when I push, it's not so bad, it's quite okay. this one over here, you can see, although the ovary is high, right, but it is actually sliding. It is normal and actually is sliding, right? So not so bad, okay? Yeah. Okay, then we look at the posterior compartment, right? The pouch of Douglas over here. And we look at the rectum and the rectovaginal septum. Now, this is something where we are not so familiar, and I want to go into a bit more detail on how you look at the rectum and the rectovaginal septum. Okay, if you look at the rectum over here, basically the rectum consists of four layers, right? You have the serosa and the subserosa, and then you have the muscle layer. You then have the submucosa, and then you have the mucosa. So how do you remember these 4 layers? Just remember, rectum has about 4 layers, and if you look at it on the scan, it is white, black, right? Yeah. So nature is fantastic. It has differentiated the layers very well for us. On the ultrasound scan, the outermost is white, then black. So your serosa and subserosa is white, your muscle is black, your submucosa is white, and then your mucosa is black again. So you just remember white, black, white, black. So these are 4 layers of the rectum. Okay. So you can see over here again, this is the first layer here, the perirectal fat. You can see is white, right? And then the next layer is the muscle layer, which is the black layer over here. Okay, and then the next layer is the submucosa, which is the white layer over here, and the next layer is the mucosa, which is the black layer over here. Okay, so this is on transrectal ultrasound, but we are gynecologists, so we will do a transvaginal ultrasound, but look at the rectum from the outside. This is looking at the rectum from the inside out, right? But we are looking at the rectum from the outside, from the vagina into the rectum. Okay, just to remind you again, it's going to be white, black, white, black. So first layer, perirectal flat, hyper that means it's white, okay? Second layer, the muscularis propria, which is black, hypoechoic. And then again, you have the submucosa, which is hyperechoic, white again. And then you have the mucosa, which is so-called black. Of course, then the interface, the probe itself is hyperechoic, so you see it's white. Okay, so when you do a so-called transvaginal mapping, you actually start at the lower vagina, especially when you want to look at the rectovaginal septum, right? And usually lower down, the vagina and the rectum is usually free of disease. So it's a very good place to start tracing from normal to abnormal. Okay, so when you put in the probe, right, you can start from the lower vagina, where you can see the rectovaginal septum, and you can actually see the rectum. Usually they'll be very smooth, and you can slide against each other. And then from there you trace up to the pouch of Douglas, which I will show you in the video later on. So your first step is to look at the segment over here, right, from just inside the vagina right up to the fornix. The second step is to go into the cul-de-sac and look at the pouch of Douglas and the rectum and the relationship to the structures over there. So again, it's a reminder. This is muscle layer, which is black, and then the submucosa, and then the mucosa. So white, black, black. Okay, yeah. And this is actually transvaginal ultrasonography. So this is a transverse view, a vaginal scan looking at the rectum. So again, you can see that when you do a transvaginal scan, it is actually possible to look at the rectum and recognize the different layers. Yeah. So the colorectal surgeons will do a transrectal scan to look at the rectum, but we can also do a transvaginal scan to look at the rectum also from the outside. Okay, so this is a transvaginal scan. This is at the second level where you are inside the pouch of Douglas trying to look at it really. So this shows there is a DIE nodule over here. If you look in, imagine that if you put in the probe, you start tracing from here. This is the first layer of the rectum, which is white, right? And this is the normal layer of the rectum, the muscularis, which is black over here. But as you go upwards towards the higher part of the rectum, you can see that the muscularis actually thicken itself. Yeah, this means that there's infiltration of the muscle layer, right, with endometriosis, because this is the low echo nodule over here. Okay, yeah. Then after the black layer, it comes the white layer, which is the submucosa. You can see the submucosa over here. Okay, yeah. So you can see that the DIE here is invading to at least the muscularis muscle, right? Yeah. Probably in some areas it may have invaded the submucosa also, right? Yeah. Well, then you have the mucosa over here, which is black over here. Okay, the lumen over here. Okay, and then if you so the rectum is basically white, black, and then you have the lumen, and then again it is black, white, black, white. So opposite direction. So if you look at the lumen over here, right? So this is black, right? And then you get a white layer here, the muscularis over here, right? No, sorry, the submucosa over here, right? And then the black layer, the muscularis over here, and then again this one here, your white layer over here. So it is white, black, and then black, white, black, white. Yeah. So it opposite, you know. Yeah. So you can actually see the whole segment of the rectum, you know, very well actually, right? So this is the patient with bowel prep. So sometimes in order to do the scan properly, we have to bowel prep the patient so that it's clean of feces, fecal matter. Then you can actually see the whole segment of the rectum. Okay, then we talk about the Indian headdress sign, right? Of course, it is not alluding to this, okay? The Indian headdress is not the nice lady, but it's actually the headdress over here. This basically means that the rectum is actually stuck onto the back of the uterus. And in doing so, it is actually puckled. So you can actually see the folds of the rectum, you know, being folded up, which I will show you over here. Okay, so when you see something like this, right, this is a danger sign, okay? There's a DIE nodule over here, and you can see your rectum, you know, being folded up like this, yeah? Right? So the Indian headdress sign is actually a bad sign. Like I said earlier, there's certain bad signs to see. So this is a bad sign. Okay, so this is the scan I've done. Again, you can see here, this is the rectum over here. Just to orientate you, this is my vaginal probe over here. The front is over on this side here with the uterus. The back, the pouch of Douglas is over here. So this is the rectum I'm looking at. Okay, the rectum is stuck onto the back of the uterus, and this is the Indian headdress sign here. You can see the folds of the rectum. Okay, now this is the video. So first thing is you can see that it is stuck. It just doesn't move. The rectum is stuck onto the uterosacral ligament over here, right? Yeah, and you can see the folds of the rectum. It just goes, you know, it just goes like a snake like that. It just goes this way. Okay. Okay, so that one is just to show you the Indian headdress sign, but now I'm going to show you the normal rectum, what it looks like, and how to trace it all the way from the lower rectum right up to the sigmoid colon. Basically, the patient is lying down, you know, in the back to the bed position, and of course your probe must point downwards towards the rectum. Sometimes the angle is actually quite high and quite uncomfortable, right? Yeah, so you have to tell them first, yeah, because when you really point down, you may be actually pressing on the clitoris. Yeah, so some patients may actually feel that it's not very comfortable for them, but you have to tell them to bear it. So you can actually see over here. This is my probe over here, right? You can see the layer over here already. Okay, so this is white, black, then white, and then black again, and then inside here this is the lumen. Again is lumen, right? And then black, and then the white, the black, and white again. So this is actually the lower anal region over here, right? I'm seeing the whole segment already. I'm seeing the whole segment here already. Okay, it is collapsed because the patient has been bowel prep. She's passed motion, so the rectum actually is collapsed and actually quite flat. Especially when you press down, the rectum will stretch out and it looks a bit more thin. So I'm just going to play this video over here, right? So you can see I'm tracing it upwards. I'm going up, right? I'm slowly going up here, right? So far the rectum looks very normal so far, okay? Yeah. It is free, okay? So you notice the rectum has changed from this way to actually this way because I'm actually moving my probe upwards already. Okay, so when I'm down this way, the rectum actually is horizontal. Okay, then I'm moving upwards, the rectum becomes a little bit more inclined. Yeah, so this is the rectum over here. It's very nice and smooth. And you need to especially pay attention to the black layer here. The black layer here is the muscularis propria here. You can see it is very nice and smooth. It is indentable. You can actually trace it. And between the serosa and your probe, you can actually see that it's actually free and it's separate from each other over here. I'll show you again. Huh? Yeah, you can see here it's free. Yeah, you can see here it's free. Yeah. Okay. Yeah. Up to here, I'm tracing up to here already, right? Yeah. So I'll show you the next one. Okay. So next one, I'm actually going upwards higher up, right, towards the uterosacral ligament and beyond. Again, you can see the white, black, white, then black inside. You can see these few layers over here. Right? Yeah. Okay. If you look over here, this is the ovary over here. I'm tracing the rectum up to the left ovary. So by the time you can see the left ovary, you are near the sigmoid or at the sigmoid junction already. So it means that you can actually trace the whole rectum from lower rectum, mid rectum, upper rectum, and up to the sigmoid even. Okay, I'll show you again. Okay, you can see here, white, black, here. It's very nice and smooth. You can see it's free, right? No adhesions, right? The whole layer is very consistent. Yeah, I'm tracing upwards. I'm going to the sigmoid. And when I can see the ovary, that is already the sigmoid there already. Okay. Okay, so this is the next video again. I show you, right? You can see the layers here very clearly, right? Yeah, white, black, right? Going upwards here. This is the ovary over here. You can see over here, right? You can see still a space over here. So up to the sigmoid is very free. So no adhesions at all. Okay, so now I want to show you what it means by rectum that is abnormal and what is stuck. Okay, so in the first part, remember when I told you that you scan from the lower rectum, usually the lower rectum is very nice, it's not stuck at all, right? Because it starts from the cul-de-sac, then it starts going downwards. Yeah, so very few patients have a abnormal lower rectum. Most of the time it's normal. So but it allows you to trace from normal to abnormal. Right, so you can see here, this is normal over here, right? And then I go up over here. But you can see once I go up to near the mid uterus, right, the mid rectum area here, you can see something that is stuck over here. But you have a nodule here, right? You have a rectal nodule that is stuck to the back of the uterus, and the rectum is stuck over here. Okay, you can see this is normal. You see, I can actually slide. I slide very nicely, right? The uterus is actually mobile, right? Because the nodule is not too big. Right, but here, once you go up to the mid rectum, it is stuck over here, right? Yeah. Okay. Yeah, this is stuck over here. Your rectal vaginal septum is actually free. This part here is free, but this is stuck. Okay? You got a nodule resting on the rectum that is stuck to the back of the uterus, in the lower uterus, mid uterus area over here. Okay. All right. Okay, I go on to the next one. Right. So again, this shows you from normal to stuck. The rectum is over here. I've labeled this the left ovary. The uterus is over here. This is the ligament over here, right? So you can see the rectum over here. There's a bit of like a Indian headdress sign over here. There's this segment that's going a little bit curvy, right? Again, you can see the lack of mobility because the uterosacral ligament here is thickened, right? And it's hardened, fibrotic. So it doesn't move very much here. I'll show you again. Right, you see it doesn't move, right? It's stuck, it's stuck here. Yeah, the rectum is actually over here. Okay, so I show you again. Okay. So you can see over here, this is the uterosacral ligament over here. You can see the white layer over here. This is thickened and fibrotic. So it's actually not very mobile, okay? Your rectal wall is over here, and over here there is a nodule over here. This is the nodule over here. That's stuck to the uterosacral ligament here. The uterosacral ligament is stuck to the back of the uterus over here. So you can see the relationship of the rectum, the nodule, the ligament, and the uterus in this one slide here. Yeah, you can see again, you can see the rectum here is having this kind of a pattern, right? Yeah, and stuck to the uterosacral ligament with a nodule over here, right? Yeah, and it's not mobile at all. Okay. Okay, so this one shows you a rectal nodule again. It's another patient. You can see the rectum over here. This is lower rectum, which is nice and smooth, right? You trace it upwards, you go upwards until you reach nearly the back of the uterus. Then you start seeing this nodule over here, right? Again, once you start seeing the nodule over here, you can see the folds of the rectum going, you know, in a convoluted fashion over here. So this is a rectal nodule over here. Okay, I'll show you another. Okay, I'll show you again. Right, this is free. Lower rectum is usually always free, right? Because you have seldom a disease going right down to such a low level, right? Yeah, but this is mid rectum. So mid rectum here, you can see there's a nodule over here, right? Probably invading into the muscle layer already. Okay, so another view, right? Here, over here. Okay, this is rectum here, you can see over here. Okay, here you can see this nodule over here, right? Yeah. Okay, already before we start. So if you look at this ultrasound, this is the lower rectum, and this is the nodule here, right? When we see this nodule, we're not supposed to measure it just diagonally across. You're supposed to trace the longitudinal length of the nodule, because don't forget, the nodule represents the puckering of the rectum. So if you have to stretch it out, then it'll be longer actually. So if you measure like this, we just measure like a 1 cm, but if you measure along the length of the nodule, it's actually longer. It will actually tell you, you know, if you're going for bowel resection, roughly the segment of the bowel that needs to be resected, you know, yeah. So it gives you a better estimation if you measure it this way. Okay, so this patient, you can see over here, this is the rectal nodule over here. This black line here, this is the lumen of the rectum over here. Okay, so you can see here, right, it's white, black, but black goes over here and becomes a nodule, right? Yeah, white, white, and then black over here, right? Yeah, yeah, but this is the lumen over here. Okay, so I'll show you. Yeah, this you can see the black here is slowly getting thicker and thicker, and then you can see here this nodule over here, right? Yeah, this is a very big rectal nodule, and actually a patient presented with cyclical hematochezia. It means she passes blood in the stools during her menses, and she started getting some symptoms of so-called bowel obstruction in the way, because she noticed a change in the caliber of stools already. So she came to me, and she's very young. She's under 30 years old only. So when I did a scan only this year, 12 February in 2020, and I saw this big nodule staring at me on the transvaginal scan over here. Okay, you can see that there is a response of the submucosa. There's a whitening of the submucosa and thickening over here, probably as a response of fibrosis and inflammation also. So you can see the thickened submucosa over here, right? And this is the lumen over here. So I show you again. Lower rectum is okay, which I didn't show, right? Yeah, but over here, this big nodule over here, right? And it's stuck, it's not mobile at all, right? Your uterosacral ligament is over here. Then I'll just show you another video. Okay, this is a bit of a closer up, right? Again, you can see the rectal layers over here. This is nice and smooth, and then bam, you come across this nodule over here. Okay, so just remember the picture on the ultrasound scan. Okay, this is the picture that you can get. Okay, so of course we were planning to go for bowel resection. We wanted to do an MRI. You remember this picture? Look at this, and then you look at the MRI picture. They look actually very similar. Now I'm going to show you the MRI picture. Okay, just remember this lesion over here. Okay, this is the MRI picture over here. Right, this is a lesion over here. Okay, it looks very similar. You can see the lesion again is got one nodule here, then another nodule, a bit like a butterfly kind of a nodule over here. And then these are the folds of the rectum that I tell you about, the Indian headdress sign over there. But the lower rectum actually is quite nice, it's quite free. The rectal vaginal septum here is actually very, very nice and free here, right? Of course, there's adenomyosis over here, you can see over here. The uterus is retroflex, right? You can see here, it's anteverted, but it's retroflex over here. And this is a nodule that's stuck onto the back of the uterus over here, right? Yeah. So you can see that whatever we saw on the scan, actually, it looks very much like the MRI. So when we train ourselves to be more experienced in transvaginal assessment, we can actually be quite accurate. Yeah. At first, when I see how people were doing it, I was thinking, how come they are so good? You know, how come they can see so much? I don't quite believe what they are seeing, but I started training myself to look at things, and then slowly you can see more and more, and then you start to believe that, hey, look, transvaginal ultrasound can really tell you a lot about endometriosis. Okay, then we go on to a few other things. Now is the bladder. Okay, the bladder actually is one of the easiest lesions to detect because it's fairly obvious. Usually the bladder is a very nice outline, very nice shape. It's very mobile, elastic, and so on. So this is a patient with a very bad history of endometriosis, who had urinary reimplantation, who then came to see me. And the first thing is I saw a nodule there, you know, yeah, okay, yeah. You can see that the nodule is in the mucosa of the bladder, okay. It is not an external indentation, it belongs to the bladder actually. The UV fold lower down here is actually quite mobile and actually quite free over here, okay, yeah. Right. But it's just the mid segment of the dome or the base of the bladder that's got this big nodule over here, and this is quite typical endometriosis over here, right? Actually, if you put a color mapping, it's actually a bit vascular. You can see there's a blood flow over the nodule and so on. Yeah. But of course, this patient, this poor patient actually suffered quite a lot already, and she already underwent, I think, at least 2 laparoscopies. So I just treated her with conservative management. Give her Bizan, because she already had 1 child, cesarean section, and she wasn't very keen to have surgery again. So just gave her Dynagest, long-term low dose, and it solves symptoms. Yeah. Although the size of the nodule didn't decrease very much, but symptomatically she was a lot better. This is a patient with also another bladder nodule, but this is actually through a transabdominal scan. It is probably a lot easier to see through a transvaginal scan, but I just want to show you that this patient was single, so I couldn't do a transvaginal scan, but even on transabdominal scan, we picked up over here, right? So first of all, if you look at this, the uterus outline is over here, right? She had some fibroids, so the radiologist said that this is a indentation by the fibroid, which I didn't agree, right? So I saw this, I said, look, this looks very suspicious, right? I think this is bladder endometriosis. We can, of course, differential when you look at this is always whether it's bladder cancer or not. So basically, she needed a cystoscopy to be done. So I asked the urologist to come in, and it was bladder endometriosis. I forgot to include pictures here, but I should have shown you some pictures where it's the typical bluish hue when you see on the cystoscopy. You can actually see over here. And over here, you can actually see the urine jet over here. So you know that the ureteric orifice is over here and the lesion is over here. Okay, so this patient we are planning, later on to go and remove the bladder endometriosis, combined operation with the urologist later on. Okay, so once you see the bladder, you can actually see the ureter. To see the ureter, you basically place the stroke in the sagittal view and then you lean towards both the left or right side. This is actually the ureter over here. You can see the bladder here, right? The transvaginal scan, this is the ureter going upwards over here. So the ureter, you can actually trace the ureter from the ureteric orifice up to the uterine junction and above it actually. So you can actually trace the part where it is most commonly affected with endometriosis, which is near the uterine artery junction. If you above the uterine artery junction, it's very unlikely that the endometriosis is going to constrict the ureter. Right? So you can see over here, you can see the peristalsis of the ureter coming in, right? It's opening and closing, it's moving, right? Yeah, so this is the ureteric orifice over here. Okay, yeah, you can see opening, closing, right? Yeah, and then you can start tracing it upwards over here. Okay, I'll just show you again, right? Opening, closing, right? Peristalsis, you can see it moving like a snake, you know. Yeah, okay. Then I go on to the next one. So this is now moving higher up already. I'm nearing the uterine artery junction. This is the uterine vein here, actually, right? So the bladder is here, the ureteric orifice is actually way here already. Right, the ureter again, same thing is opening and closing, peristalsis. You can see the uterine vein over here, right? Yeah. Okay, the next one I will show you. Okay, here this is the uterine artery over here. You can see. Wait, no, sorry, not this. Okay, here. Right. So you can see the uterine artery over here. Then you can see the ureter actually crossing underneath the uterine artery over here. Then you can see the peristalsis is crossing here like this, right? So you can see the ureter up to here. This is at least, probably at least 2 or 3 cm above the uterine artery junction. So if you can see the ureter up to that point in time, then it's very unlikely that there's any involvement with endometriosis of the ureter. Here you can even see the ureteric jet, right? You can see the ureter shooting out. You can see the orifice here, right? So this is a ureteric jet from the orifice, right? I thought it was always good to train to see the ureter because we do a lot of hysterectomies, whether it's laparoscopic or open or otherwise. And then sometimes we are not very sure, whether the ureter, is in any kind of risk or not. So you can quickly put out your office and look at it and so on. Of course, it doesn't guarantee, but it's another assessment method that you can actually check for the ureter. Okay, so now then we come on to the pouch Douglas and the uterosacral ligament. Usually what you do is you put your probe in the center of the uterus, of the pouch Douglas, and then when you lean towards either the left or right side, you will start to see your uterosacral ligament. This is probably the hardest part to learn because it's not easy to see because when does it become uterosacral ligament and when does it become peritoneum? It is a fine line. So even in laparoscopy also or surgery also, we say this is the uterosacral ligament, but exactly where does it start or how do you isolate it? It's not that easy. Okay, so you can see here this is the uterosacral ligament here. It's probably a white fibrotic line, but this patient is actually quite nice. She doesn't have any endometriosis. The uterosacral ligament is elastic and it's quite smooth and it's mobile. Okay. Okay, then look at this. Okay, so this is the thickened uterosacral ligament, which is stuck to the back of the uterus over here. Okay, so the lower part of it here, rectovaginal septum is actually very nice. Okay, but this is the uterosacral ligament over here. The rectum is somewhere over here. Okay, it's stuck to the back. So as a result, you can see this uterus is retroverted and probably retroflex also. Okay, same thing you can see, right? Yeah. Okay, so now this part here is the rectum over here. This is the uterosacral ligament. Okay, so rectum is actually not too bad. It is not stuck. Rectum is actually quite free over here. You can see over here. But your uterosacral ligament is thickened, fibrotic, and is stuck to the back of the uterus. Okay, now we don't see this one. Okay, here this is thickened over here. You can see pouch of Douglas is free, right? Rectum is behind, it's quite free, but right uterosacral ligament thickened, fibrotic, stuck to the back of the uterus over here. Okay, it is not too bad because you can see over here, you can still see your pouch of Douglas over here. I'll show you again. Right, this is the pouch of Douglas. This is your rectum over here, but this is your uterosacral ligament. Right, so obviously it is not normal. It's very thickened, right, and it's stuck. Okay, and I'll show you what it looks like on laparoscopy. This is the same patient. You look at this right uterosacral ligament over here, right? You can see the pouch of Douglas is quite free. The rectum is free, but your uterosacral ligament is thickened, is fibrotic, which you don't see so obviously over here, but on your ultrasound, you can actually see that it's very thickened over here, right? So this is deep endometriosis invading inside, but when you look at laparoscopy, it's not too bad, but you can see this is you can appreciate this is a thickened uterosacral ligament, but your rest of the organs not too bad, not really that stuck. Okay, so you can see now this is the uterosacral ligament nodule you can see over here. Okay, I will show you. Right, the uterosacral ligament is over here, right? This part here is thickened, right? You can see there's a nodule here. There's a low echo shadow, within the uterosacral ligament. Yeah. Right? It's not so bad. It's not as thick as the previous case, but it's still thickened. Okay, so the key points I want to emphasize today is that the transvaginal scan actually provides us a window into the extent of the endometriosis. It's like staging the endometriosis before we even go in for the surgery. And the fact that we can do dynamic scanning, it gives us an edge over other modalities, even MRI. So because you can actually explore the relationship, between the organs. And I would say that mapping for endometriosis is essential, and it's got implications for the success of treatment, whether medical or surgical, and it's got impact on the patient's fertility, ovarian reserve, and recurrence, right? And this is actually very useful information for the surgeon before going in. So that's why I decided to take this up, because I'm a laparoscopic surgeon, okay? The last thing I would imagine myself 5 years ago was to give a talk on ultrasound. Okay, usually my talks are on surgery, laparoscopic, and otherwise. Yeah, so I just feel that this is very important for us to know. So I think I now pass on the chair back to Ulrich, and then I'll try to answer questions if I can.
Thank you. Oh, this is wonderful lecture. Is especially for the ureter. Okay, I'm very surprised that we can look for the ureter by the transvaginal ultrasound. It's very surprised. And I have my good friend who have a lot of experience on ultrasound in endometriosis in Thailand. Dr. Pasama, can you share the experience in Thailand? Can you unmute your own microphone?
Sorry, I still keep it muted. Okay. First of all, I think I have to thank you, Professor, for the very clarifying and it's very brilliant point. Actually, what you did, what you are doing is also my current practice. But generally in Thailand, not many doctors can perform it well. It needs some training, and actually, first of all, I think it's the setting of the machine to make it a high frequency and high resolution, or else it's not gonna represent any good quality image like you did. That's the point. Usually, doctor here, we just turn the machine on and we can just examine whatever it's set, which is not correct way to do it.
I see. Thank you, Dr. Pasama. So, in your opinion, Dr. Fong, in your opinion, compared with the MRI, do you do the routine MRI for the patient?
No, I mean, already the 2016, consensus paper says that transvaginal ultrasound should be the first modality assessment. Yeah. Only when we can't see, or sometimes we cannot do a transvaginal, for example, in single or young girls, then you are forced to do an MRI. Sometimes I will talk to them, I will ask them whether they allow me to do a transrectal scan or not. Because I'm sure a lot of you have experienced, you can do a transrectal scan. It looks exactly like a transvaginal scan. And then you can see, start to see certain things also, you know. Yeah, but if they're not so keen, then I'm kind of forced to do an MRI because it's very hard to assess with a transabdominal scan. You can't see so many things here. Yeah. Especially the parts of Douglas is just too far away for you to see.
I see. And in the other way, how about for the fibroid, especially for the myomectomy? Do you do the routine MRI or just the underside? Is that enough?
No, selected patients. Most of the time, I don't do an MRI for fibroids unless I've got problems. I can't see or I want to be more sure. Because sometimes when we have a very big fibroid, it will block your access to the rest of the uterus, and then you can't see, you cannot comment very much. So then you need a MRI. Yeah.
I see. Thank you very much. Oh, it's almost 1 hour. It's almost 1 hour. But I think that this is an excellent lecture, and who knows, in the future you are the lecturer for the underside. I mean,
I don't know.
I mean for the workshop, because this is should be the routine investigation for the gynecologist.
Yes.
Okay,
And
everybody can do the transvaginal, but they have to know more and more about the information or looking for some the diseases of the endometriosis.
Yeah, correct. Yeah. I mean, I think it's important to share it so that more people will realize that they can actually pick up more. And actually, if you look at it, it's actually better for the patient. You know how bad it is, then you can ask the right people to tackle the endometriosis, for example, or you can ask for help, or even ask a colorectal surgeon to stand by so that you know they are coming in and so on, kind of thing. So it's actually, in the end, better for the patient.
So, last and not least, so thank you very much, Professor.
Thank you.
Thank you.
I want to thank Obstetrics, and then I want to thank the Thai College of ONG for this kind invitation and this chance to share with everybody. I'll be happy to share in the future as well. So thank you very much, Obstetrics.
Yes, thank you. And the last, because you are the host after this meeting, when you leave this meeting, the video will record on your computer.
I put it to the cloud, so I'm not sure.
Oh, okay, it's on the cloud, right? So I think somewhere. Okay, but I think it's after this day is finalized, it's on the cloud somewhere. So maybe it's sent to me or sent to you. Is okay. We can check for it. It's okay.
Okay.
After this.
So
by the way, thank you very much.
Okay,
and
thank
we
you.
should see you in Thailand or in Singapore. It's okay.
Yeah. Take care.
Take care.
Okay. Bye.
Okay. So next time we will have a jumbo together.
Yeah. Let me see how to do this.